Today I'm going to talk on a very basic topic in anesthesia, that is PDPH. It so happened that recently I got a call for one VIP patient to administer one epidural blood patch for PDPH. As you know, this patient was super VIP, and there are chances that during administering epidural blood patch, there can be again dural puncture. So it was really stressful, but it went well, and patient got relief for almost 4 or 5 days. And again, I got a call that same patient was suffering from the headache. Now, case was discussed extensively with team of doctors, including neurologist, neurosurgeon, and what to do next. And we sit together, talk on that case, and we decided that we will again administer second blood patch. In my career, I have never administered epidural blood patch twice into a same patient, that to a very, very VIP patient. And for that, I extensively searched the literature. When I searched the literature, I found that so many new things are come up in this post-dural puncture headache. And whatever our old age concepts were there, they are changing very rapidly. So I thought, why not to discuss this in front of all of you? So I prepared this topic, and today I'm going to talk on this post-dural puncture headache. The history of post-dural puncture headache is quite old. All of you know that August Beer invented the spinal anesthesia, and he himself took this injection of cocaine into his spine. And later on, he described that for next 7 days, almost he was feeling headache, dizziness, and it was a classical post-dural puncture headache. Now people have, as this spinal anesthesia was invented, people very soon realized that this problem of post-dural puncture headache, and they tried so many treatment like from ethanol, even IV ethanol, spine manipulation, till 1960 when there was a breakthrough or someone suggested to administering a epidural blood patch. Now, what is the current relevance of this topic? At the time of Beer, the incidence was around 50%, and in 1950 it was 10%, and currently it is below 1%, thanks to the advancement in science. But in obstetric, incidence is quite high, 1 to 1.7%. And for obstetric anesthesia, when you give epidural puncture, there are high chance of accidental dural puncture, and which again increases the chance of post-dural puncture headache. This incidence of PDPH is very high in radiological procedures. Of course, they are invariably done by a non-anesthetic person. Very large bore usually used, many times multiple attempts made. All these are factors responsible, but even today the incidence is almost 10%. Let me tell you at this juncture that whenever you are performing spinal or epidural, it is better to take the informed consent of the patient about this PDPH, and it is very, very important. Now, what is the pathophysiology? All of you know that CSF get leaked. When it more than 10% CSF get leaked, there occurs low CSF volume, which causes CSF moves in out of spinal canal, and then brain moves and it loses the cushioning effect, which causes downward trends, tension on meninges, nerves and vessel, and which produces the pain. And this is also radiologically proven. Another, there is one law that invariably brain keeps its volume constant. Now to compensate this law, there occurs a vasodilatation. Now this lost CSF has to be replaced. Now how it gets replaced? There occurs a vasodilatation, increase intracranial blood volume, maybe due to arterial and venous dilatation. And again, it is also proved in a Doppler ultrasound. All this leads to an increase in the headache. So there is around 150 ml patho CSF. When you lose more than 10%, means even 50 ml of CSF is lost, there are chances of PDPH. And as I already discussed about this traction on pain sensitive structure, which produces the pain. Now, what are the symptoms? Invariably, This loss of CSF causes traction, and traction on all our cranial nerves. When there is a traction on ophthalmic nerve, it will cause a frontal headache. When there is a traction on our cranial nerve 9 and 10, usually cause occipital pain. If there is cervical nerves, it get traction on C1, C3, we get a shoulder pain. Nausea can occur due to vagal stimulation. Then even the CSF is deeply connected with a perilymph in the ear. So there will be auditory and vestibular symptoms. Visual disturbances can occur due to this ophthalmic nerve, certain branches of ophthalmic nerve get affected. Now, what are the clinical features? Onset is usually after 12 to 24 hours, and it lasts and it remains for 2 to 5 days, and it may remain till up to the 7 days. Usually bilateral postural headache is the cardinal sign of PDPH. Usually it is relieved by lying down, associated with neck stiffness, tinnitus, diplopia, hypoacusia, means less patient, his sensitivity towards acuity is decreased, hearing sense. You must categorize patient on VAS scoring, whether it is mild, moderate, and severe, because our treatment plan is going to change on this VAS scoring category. Many times we saw that patient complained of headache immediately after 1 or 2 hours of procedures. So it has been attributed that if patient is getting headache maybe 1 or 2 hours, particularly in epidural, maybe due to this pneumoencephalus in epidural space when you use the loss of resistance technique by ear. So in epidural, if this is happening, this can be the cause. International Headache Society has given a diagnostic criteria. A positional quality worsening within 15 minutes of sitting or standing and improving within 15 minutes after lying down, which is headache, which is a bilateral, is usually the PDPH. I just given a criteria, headache accompanied at least with one of these symptoms is PDPH. So our diagnosis of headache should always be PDPH, should be based on all these criteria. Now, what are the risk factors? In which patient is it common? Now, peak age is around teenager group to 30 or 40 years age. It is very rare in pediatric patient and elderly patients. Of course, females has got more chances of headache because invariably in pregnancy it's very common. And if there is a history of PDPH, then again incidence is very high. Low BMI is an independent risk factor because high BMI, obesity decreases risk because there is possible due to increase intra-abdominal pressure, which probably decreases the chances of PDPH. It is proven in retrospective analysis that cigarette smoking, there is a lower risk of PDPH. And any headache, patient, if given a history of any headache, there is a strong association with a PDPH. Now, these are the inherent risk factors, but what are the modifiable risk factors related to procedure? Larger the needle size, all of you know, high chance of headache. Multiple attempt, inexperienced operator, high chance of headache. Cutting versus non-cutting needles. This is non-cutting needle and this is cutting needle. When you use cutting needle, you create an abnormal rent in the arachnoid matter, dura matter, which increases the risk of leakage. That is why, which delay the healing of this layer. That is why chances of headache is more. If bevel is perpendicular, means if bevel is parallel to the long axis, this rent will be like this, and as scar contract, there are less headache. But if bevel is transverse in direction, in this way, there are high chance that more CSF leaks, more duration of CSF leak, and headache may be the more. Now, can you prevent it? Yes, a clever person solves a problem, but a wise person always avoids it. So always use the smallest feasible non-cutting needles. If you are using the cutting needle, bevel should always be parallel to the spine at the point of entry. Then there is a very interesting paper which I'm going to discuss in later part of discussion. If you replace the stellate before withdrawing the total needle, there are less chance of PDPH. I will come to this point in later part of discussion. accidental dural puncture, the incidence is less than 1%. You must yourself observe how much is your incidence of epidural accidental dura puncture when you are performing epidural. If it is more than 1%, there is some problem in your technique. If you use saline versus air, air has got almost 10% more chance of accidental dura puncture as compared to the saline technique. Now, invariably, whenever such PDPH occur, we tend to tell the patient that you should immobilize, take maximum rest. But on the contrary, early mobilization is preferred, and we tend to give more fluid. We ask patient to drink maximum water. We give IV fluids. But it has been proven in multiple studies, which I'm going to discuss in my subsequent discussion. Overhydration is not at all useful to decrease or prevent the PDPH. Now, a recent review, there are so many drugs that has been used to prevent the PDPH. But recent review of drug therapy for preventing PDPH, 10 RCTs has been reviewed, and they all find that none of this drug is useful to prevent the PDPH. So unnecessary giving all this oral caffeine and morphine and all this, they are not going to be useful. Till that, there is no evidence to support that common practice of recommending bed rest and aggressive hydration in prevention of PDPH. This is NISORA has clearly given it even on their website. Now, replacement of the stellate before withdrawing the needle. There are multiple studies which has shown that it's our usual customized habit that once you are successfully given the spinal local anesthesia into the dural space, you immediately withdraw the stellate. But you should put the stellate inside the needle and then withdraw it so that that rent is uniform. When you withdraw the needle without putting the stellate, there can be when you are taking out the needle, there will be additional trauma, or that rent will be a with zigzag pattern of rent, which will cause a more CSF leak. And that is very common, and it's proven in studies. Then is there any role of prophylactic blood clots? Suppose I'm giving epidural, I find that suddenly this patient is very prone for PDPH and accidentally I punctured the dura. So there is no role of prophylactic blood patch. There are few studies which support this, but RCTs and meta-analysis don't support this. Many times, suppose there occurs a dura puncture, it is advisable that you infuse the saline into the epidural space or into the dura so that CSF volume will be replaced and there will be a less headache. But this technique is also not very useful in preventing PDPH. And fluid and bed rest are not very useful. So none of them, this is found to be very useful. Now PDPH occurred. Now how to treat this PDPH? Our aim is to replace the lost CSF, seal the puncture site, and control the reflex cerebral vasodilation that is occurring. Now, how we can do all this thing? So usually PDPH is self-limiting process. If untreated, 75% or 80% of the time, it will weak. But if it is not resolving, it has to be treated more aggressively. Now, treatment, bed rest, as I already told, 47 trials concluded that bed rest for PDPH would not identify additional benefits. And even further studies are unnecessary. It has been clearly told in that review. In summary, in that time, there is no evidence to support the common practice of recommending bed rest in prevention of PDPH. Simple analgesic antiemetic, yes, you must give. Then fluids, no evidence that vigorous hydration has any therapeutic benefit, that it encourages the increased production of CSF. Only thing is, no PDPH patient should allow to become dehydrated. So you maintain the good hydration of the patient, but there is no need for the hyperhydration. This is the clear-cut message. Now, we prescribe so many these drugs, particularly caffeine tablet, because it is said to have a cerebral vasoconstrictive property. We always advise the patient to drink the black coffee or Suminac or sumatriptan, serotonin receptor antagonist, this gabapentin, ACTH. Only pregabalin has been found to be useful in the treatment of PDPH, and in multiple these trials it has been, and these all are recent trial 2020, and all these trials they have shown that it is not going to be very useful. Only pregabalin, because it acts on alpha 2 and delta receptor, which may decrease the pain substantially. So pregabalin may be the useful. Otherwise, this ACTH, people have used cosintropin IV and analog. There are one or two successful papers available on this, but all RCTs, all meta-analysis don't advocate this pharmacological agent in PDPH. Now there are nerve and ganglion block, what is called as NG block, to treat these are the some different way of treating the PDPH. One of them is greater occipital nerve block. It is said that there is a traction on these nerves which are causing the occipital headache. It is very easy to block this greater occipital nerve block because these are superficial nerve. This is the occipital protuberance and this is a mastoid. Draw one line, divided in three parts. This is medial 1/3, lateral 1/3, and middle 1/3 and lateral 1/3. Between medial 1/3 and lateral 1/3, there is a greater occipital nerve. Between middle 1/3 and lateral 1/3, there is a lesser occipital nerve. You can also give this block ultrasonographically. And there is no need to give even ultrasonography, just you have to inject 1 or 2 cc drug is these 2 points, and many times patient get a very good relief. It is said in one paper that almost 90% times patient will get a relief with occipital headache when you perform this block. But the disadvantage or the drawback of this study is only 16 participants have been studied in this paper. And all the subsequent paper for greater occipital nerve block have come from only one center. So how much it is reliable, we don't know. Similarly, spinopalatine ganglion block. Spinopalatine ganglion block is this spinopalatine ganglion controls the sympathetic and parasympathetic system of our head. Now, if you block this spinopalatine ganglion, it will prevent or it will reduce its vasodilatation. And once this vasodilatation is minimized, less blood, there will be a vasoconstriction, and which will decrease the headache. This was the concept. And this is a very easy block. I mean, just you put one cotton gauze in the nostril, which is soaked in 4% xylocaine, and again sprinkle some 4%, 1 or 2 ml into this nostril, or just even with syringe, ask patient to take a sniffing position and deposit some 4%, 1 or 2 ml through nostrils, and ask patient to remain in this position for 10 minutes. And many times patients get a relief from the headache. This is the concept. So it has been described in literature that these two blocks are very, very useful for PDPH rather than going from epidural blood patch. If you go with this two block, there will relief to the patient, but this needs further studies. So at this juncture, you cannot say that this is going to be helpful, or we will have to try, but studies with very minimal number of patients. So we have our fingers have to be crossed for this sort of treatment. Now, epidural blood patch. Gold standard for PDPH is epidural blood patch. Mechanism of action is very simple. This autologous blood is when inserted into the epidural space, there will be inflammation. That inflammation will seal that leak. Success rate is almost even with best of hand, it is 50 to 70% success rate. How much blood volume is given? In one RCT, they have compared 3 volumes, 15, 20 ml and 30 ml. And they found that for 20 ml, there is a maximum 73% relief. So right now we are using a 20 ml of blood for autologous. Optimal site is when you give blood 3 side upward, means 3 vertebra upwards and 1 vertebra downward is the spread of that. It has been proven on MRI scan. So you find out the site at which lumbar puncture has been done and administered epidural blood patch accordingly. And this will clear cut block the leak, and this is the most proven technique for severe form of PDPH. In resistant cases, surgical treatment is recommended. But the most disadvantage of surgical treatment is we have to find out where is the location of leak. And for that, you have to do myelography, means you have to again puncture the dura. So when you want to go for surgical intervention, you have to first prove on myelography where is the dural puncture, and that is the biggest disadvantage of surgical treatment. Is there any recommended literature supports multiple epidural blood patch? Yes. There is one very large study, I think from Canada in Obstetric Anesthesia Journal, of 84,000 parturient undergone spinal anesthesia. 753 patients suffer from severe headache, and out of which they have administered 394 patients, they have administered epidural blood patch, out of which 66 patients they have to administer second blood patch, and in 6 patients, means 1.5, they have to administer 3 blood patches. This is the only study available, and we can give in a very rare cases multiple epidural blood patches, and it has been supported through the literature. Now, why I'm talking or why we need to discuss PDPH, is it a really dangerous problem? Or is this PDPH has got a long-term sequelae? Unfortunately, yes. If there is a PDPH, there is one very interesting paper in anesthesia, persistent headache and low back pain after accidental dural puncture in obstetric population, a prospective observational and multicenter cohort study, that in some patients, this sequelae of PDPH will be a persistent headache and low back pain. And this is a very unfortunate, somebody is getting a PDPH and he is suffering for maybe 10 years with persistent headache and low back pain, and this is not a very good thing. So there is definite prognosis of PDPH in this way, so one must be extremely careful. So we have demonstrated in that paper that accident is associated with long-term morbidity, including persistent headache in parturient. This challenged the current definition of post-dural puncture headache as a self-limiting condition and raises plausible clinical, financial, and medico-legal consequences. Another interesting thing is that, is there any association between PDPH and subdural hematoma? And unfortunately, there is an association in PDPH and subdural hematoma. First paper in this regard was from a small case study of 56 reported cases of subdural hematoma, and they retrospectively analyzed and they found that few of them were having PDPH. Now another study from Canada where they studied 26 lakhs patients, means almost more than 2 million patients they have studied, and they found that incidence of subdural hematoma in a PDPH patient is more as compared to normal population. In normal population, subdural hematoma risk is 1.5 per 1 lakh. In PDPH patient, it is 145 per 1 lakh. Means as compared to normal patient, this chances of subdural hematoma is 200 times more in a case of PDPH. So it's not a very self-limiting condition. So we have to be extremely careful, extremely vigilant about avoiding PDPH and treating PDPH. And the mechanism why subdural hematoma can occur due to decreased cerebral fluid pressure. There occurs a gravitational traction on brain structure, which causes subdural vein rupture and subdural hematoma. So we have to be extremely careful about this. Whenever you get a patient of post-dural puncture headache, divide them in mild, moderate, and severe form. And if it is a moderate to severe, just try pharmacological treatment, maybe for 24 hours. And it is not subsiding, immediately go for the epidural blood patch. It is a very safe technique, and most of the patients get relief with the epidural blood patch. And that is what I wanted to convey to all of you. So the take-home message is PDPH is mostly a non-avoidable problem, even after highest precaution, but incidence must be minimized with the measures we have discussed. Avoiding dural puncture with large bore needle, multiple punctures, parallel beaver direction, And replacement of stellate for needle withdrawal is very, very important. Strict bed rest and overhead hydration is not necessary. Peripheral nerve block may be future, but it has to come to through multiple studies and RCTs. And EBP is the most effective treatment modality till date. I wish all of you a very happy Ganesh festival. Sarve bhavantu sukhinam, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschita bhavet. So may everyone be happy, may everybody be free from disease, and may everybody have a good luck without any evil. Thank you very much.